I'm Rashmi Halker Singh. I'm the Deputy Editor of Headache. It's my pleasure to be joined today by Dr. Jennifer Robblee, who's the first author of a recent narrative review entitled Redefining Status Migrainosus. Welcome, Dr. Robblee. I'm so excited to have this conversation with you.
Well, thank you for having me. As you know, status migrainosus is one of my favorite topics, so I'm excited to get into it.
So first of all, can you explain what prompted you to take on this topic at this time? Was there a specific clinical moment or frustration with the 72-hour role that motivated you to do this review?
So we have been working on this for longer than one cares to admit. So when I was chair of the refractory SIG, we would have debates about status migrainosus and debates about refractory migraine and what we thought both were. And when we would talk about status migrainosus, there was actually varied opinions on how you should approach it, when you should treat it, what you should do to treat it. And it just was very clear from a group of people who were passionate about it that we had a lot of different opinions and that there really wasn't great guidance. And we were left with, an ICD criteria that doesn't actually help us that much clinically. So initially we were going to do this as a larger systematic review, but honestly, there just was no data. So it turned into kind of this smaller narrative review that built up to several questions that we worked to answer with what was available, which is sadly limited.
So you shared that there's a problem with the ICHG3 definition. I mean, really in headache medicine, everything that we do falls back to the ICHG3. So in one sentence,
Yes.
What is the problem with the ICHG3 definition of status migrainosus?
Yeah. So picture your own clinic. When a patient reaches out to you and says, I have a headache, my home medications aren't working. I mean, sometimes it's been greater than 72 hours, but often it's not. They usually know that day or by the next day that it's not working. And we have a huge gap in our guidance. We have what to tell people to do at the start of an attack. Then there is absolutely nothing in the literature until they end up in the emergency room and we offer them parenteral treatment. And the reason for that gap is we don't really have words to describe that. If it's greater than 72 hours, we call it status migrainosus, but no one's waiting and saying, sorry, we got to wait till the 72 hours till I use my status migrainosus approaches. It's just not the reality of how we practice, the reality of how patients present. And it's resulting in actual patient harm because we don't have any guidance on what we should do when home medications aren't working.
Absolutely. I mean, this is the reality of practicing headache medicine in our current time. What did you learn about the 72-hour cutoff? Where did we even come up with that number as that's how we define status migrainosus?
So it's based on pretty old observational data. So if you look back at some old studies, they took a series of patients and looked at how many had a headache lasting, in that less than 4 hours, that first 24 hours, 24 to 48, 72 hours, how many were after 72 hours. And backroom conversations back when IHS made the initial ICHD, what we now call ICHD1. Basically, they looked at it and I guess said, well, most of them fall within this 4 to 72 hour point. Let's make migraine 4 to 72 hours. Well, what happens if it's longer than 72 hours? I don't know. Let's call that status migrainosus. And as best I can tell, that's basically what happened. And I was able to talk to at least one person who was a part of that process, and they did verbally confirm that that is essentially what happened. And here we are decades later, and we have not changed it. And there is zero evidence to tell us if there's something different between 4 to 72 hours and 72 plus hours. There's nothing to support that that is actually pathophysiologically different.
Wow. You mean to be in the room where it happened, right?
Right? So that is like one of the core parts of our definition of migraine. And it's based on just some old observational data.
That's incredible.
I know, it's kind of eye-opening that that's what we've used. And I think part of the problem is because no study has said that there's anything different. From talking to people who have been involved in kind of updates to the classification system, there's no impetus to change it because there's no updated evidence to say, well, this is the better answer.
Especially when
So
we
we've
think about the fact that now we discuss about how migraine steals so much time from a person. We really think about the patient voice in everything that we do. And this really is a core tenet to practicing migraine care in the current era, to think about the fact that it was just a table side conversation about, I think this is a good idea, let's go with it. And here we are decades later.
I
You
know,
you
right?
you really talk about the fact that the term debilitating also appears in ICHG3, but it's
Mhm.
not defined either. Can you explain why that's also problematic?
So it says that it needs to be debilitating, and I can pull you the exact wording here because I want to make sure I get it right. So what it actually says is, let's see.
Well, while you're looking for it, I'm going to ask you another question. You do say that disability might matter more than pain intensity. Can you talk to that
Mhm.
point a little bit and explain what we should be measuring in clinical practice?
So, okay, I do have, so I have.
Okay, well, two questions
All
then.
right. Yes. So going back, so debilitating attack, basically, it's pain and or symptoms are debilitating. First off, what pain severity is debilitating? Is a 5 out of 10 debilitating enough for that to be status migrainosus? Does that mean it has to be severe? So what about a 7, an 8, a 9? Does it have to be a 10 out of 10? That's not defined. What if the pain is a 3, but they're so cognitively impaired during it? Does that count? Or are we talking about nausea, vomiting, photophobia, phonophobia? And then getting into one of the later questions, what about if their prodrome was exceedingly debilitating? Does that count into it? And then if so, when does the clock start? So there's just so many elements of that that are just vague. And if it's vague, it means when we study it, we're going to have variations between who we study. And that means it's going to be really hard to interpret results of any study that has been done.
Well, you really led into my next question, because right now I think within our migraine community we're really emphasizing onset of migraine and how it doesn't begin with pain, really talking to our patients about that so that they can have a greater sense of control over these attacks as well, talking about the prodrome, really educating our colleagues about that too. And I thought that was just so thought-provoking about whether we should be counting the prodrome phase as the beginning of the attack, and should that count even towards the hours that we're including in status migrainosus? Can you speak to that a little bit?
I mean, my opinion is I don't think we have enough information or data that something like status migrainosus, if we continue to use time as a key component of the definition, to say that the aura, the prodrome, the postdrome should be included in it. But I do think ICHD4 needs to start including in how we define migraine consideration of all the different phases. And if we're going to include those, that then has an impact on how we then define status migrainosus, because then we need to be clear about what parts are part of the time duration. I mean, they're definitely debilitating. I think we need studies to better understand what the duration of an entire, start to finish migraine attack actually is. I don't think there's enough data there just in general to make a change, but I do think it needs to be in the criteria, and we need to define in the criteria, start to finish status migrainosus means this piece of it.
So as you think about the fact that there needs to be a revision to the diagnosis or diagnostic criteria for status migrainosus, or, for many colleagues right now working on the next iteration of the ICHD, what research question do you think needs to be most urgently answered before this revision even happens?
I think we need to actually understand at what point do biological changes happen in a migraine attack. We need longitudinal multi-point studies of everything from biomarkers to symptom tracking to neuroimaging, functional and structural, all of those things, so we can understand a migraine attack starts to change at this point, and then perhaps at this point, this is when it no longer responds to typical treatment. So we need to actually understand where those progressions change. So for instance, we do have a sense that once you get to the point of allodynia, there's central sensitization happening and medications don't tend to work as well. But that allodynia can happen at many time points for many different people. For some people, they just have baseline allodynia. So are they essentially never out of a migraine attack? We don't even really know the answer to that for patients with constant headache and constant allodynia. So we need to start to actually understand when we look at our complex patients, what the biological phases are and not just what the clinical phases are.
So you've done such a wonderful job raising so many important points and, problems with the current definition that we have with status migrainosus and really the lack of research that we have to help guide care. Having said that, so many of us take care of patients that live with migraine and status migrainosus every single day. For the clinicians who are watching this interview, what change do they do in their clinical practice, today, tomorrow, when they think about or manage the next person who comes into their office with status migrainosus?
I mean, take this all with a grain of salt because this is my own opinion and I don't have research to back it. But in my own practice, I like to make sure that patients have what I say, a lot of tools in their toolbox. We talk about steps and we talk about stratification of care. And I think we actually need to do a combined method for our patients. It might be they have mild headaches, they have severe headaches, and then they have severe headaches that don't respond to the first step. And I think they need options for all of those and sometimes even more. So perhaps they have a mild headache, something, that they can use that usually works for that. Maybe it's the same for their severe headaches, but maybe it's not. So again, that's where we're talking about what you do differently for a mild versus a severe headache. And then if that typical home treatment doesn't work, we don't just leave them then be contacting us with what to do. They need a backup treatment. And you need to teach them when and how to use the backup treatment. That first step might be, hey, you've got your sumatriptan, it's been 2 hours, it didn't work. Make sure you're using it again at 2 hours. But now another couple hours has gone by and it's not worked. They need to know what to do at that step. And so I use what I can pull from the evidence and kind of concoct different options for patients that over time I've refined the options that I find work for my patients. And we try to come up with an individualized care plan. So then if that step doesn't work, and they often get beyond that point, at what point do I start to initiate something more aggressive, like maybe letting them do an injection at home of ketorolac, or even having some steroids at home if it seems like they're really getting into this prolonged attack. And then for patients where they are prone to getting into these long attacks, having something like an infusion clinic set up or a way that they can come in quickly for an IM injection or come in for a nerve block or something like that. So you need to have those steps in their care. So we keep them out of the emergency room because then we're just following to those guidelines, which, great, we at least have some guidance there, but try to fill those gaps with what you can best pull from the research. So for instance, I know that there's good evidence for prochlorperazine IV. Why not use that in a pill form? We have it. There's a bit of evidence for divalproax. Why not use it in the pill form? We have it. There's evidence for using dexamethasone to prevent recurrence. You don't want to do it too often. You want to be really cautious and lots of counseling, but why not let them have that at home for those scenarios where it's appropriate to use it? And then how you combine those. I mean, there's so many variations, but those are the types of things that I do for my patients. And you got to let them know that you're going outside the box. You don't have good evidence on what to do, but you also don't want to leave them with no options, feeling completely out of control.
I think that's great advice. I think, what I'm hearing from you is that you do a lot of listening, a lot of patient education, and really giving them a lot of options, which I think is so important.
Yeah. And I mean, I try to pull from the literature and see what I can do to convert it to something that's appropriate for home use. And then sometimes you get to the point where you really are just going on spec. This makes some conceptual sense. Let's try it. Like, for instance, there's, the new medication, what is it? The suvexatrines or the Jernavix. There's no evidence of migraine, but I've had some patients that I've tried it when they're kind of in those types of stages, super hit or miss. I counsel them that it's been studied for postoperative pain, not for migraine, but it's a medication that's meant for pain, if you can get it. So those are where you're kind of with your refractory difficult patients who just don't respond to the options. Again, use the best evidence that you can and apply it as best you can to your individual patients. but don't leave them with nothing. And if you don't have any other options, at least support them through it and suggest what they can do, be it, try and use your triptan every day till this one breaks, and we'll get you in for some infusions or whatever else you can come up with.
Maybe write up some case reports on some of these novel
Yes,
therapies.
yes,
So,
please write all the things
we
you
have
do.
some additional data.
Yeah, that would be great. And, get some, criteria down where it makes sense to study and we really have a good homogeneous group. And let's actually do, observational study, maybe, heaven forbid, a randomized controlled trial on some of these.
All right. Well, thank you so much for taking the time to speak with me. I think this is a really interesting paper, and we really look forward to more work from you and your colleagues.
Awesome. Well, thank you so much for having me. It was something that was definitely a project of passion, and hopefully at least opens people's eyes to some things that we need to work on.